Welcome, everyone. I'd like to introduce our first speaker. We have Dr. Anup Khateria. He is an associate professor of pediatrics and the director of the Neonatal Research Institute and the NICU follow-up clinic at Sharp Mary Birch Hospital for Women and Newborns. He will be presenting cardiopulmonary monitoring during resuscitation.
Thanks, Emily. Let me just get my slides up here. All right, and so for my talk, I focus mostly on delivery room resuscitation, not only because that's where most of my work and experience with monitoring lies, but that's really where most of us perform resuscitation. But many of these modalities could be used in the NICU as well. No disclosures, but keep in mind that many of these devices are not FDA approved, at least for us, those of us in the United States, and you may need to also check within your own countries whether or not these can be used clinically. So mostly they are available for research purposes. So why do you want to focus on delivery room resuscitation particularly? It's always been an interest of mine, and I think for most of us, we know that babies do have these dramatic changes in hemodynamics at birth. And simple things such as detecting a reliable heart rate can help guide how we manage our resuscitation. We also know changes in lung compliance occur very rapidly over just a few breaths and injuring the lung if ventilation is not adjusted either up or down. And similarly, we're also trying to titrate oxygen because we know that hyper and hypoxia can both be harmful for the brain, heart, and lungs. And right now we have these sort of three areas that we use for monitoring. Auscultation, which has been there for decades, has its limitation that it's unreliable and often underestimates the true heart rate when compared to ECG in a number of studies. ECG is great, but it's not always widely available. And that being said, you have to have other information with that as well. Pulse oximetry has long been there for our real first line monitor for babies, but now we've learned from a number of studies that it can be delayed in terms of providing heart rate information in the first few minutes, and even getting oximetry data in the first minute is pretty rare as well, because you need perfusion to be able to get an oxygen saturation. And so we've really moved to a number of new methods, at least in the research scope, and some of them have been adapted towards clinical practice. And I won't read all of these here, but they're on the slide just to think about as I go through this talk. And so when you think about how to integrate it, this is our setup here in San Diego, where we've taken just a standard bed, could be from any company, but many people use a bed similar to this, or shown over here on the right, and you adapt it to put in a number of different modalities. We use video cameras as well for quality assurance as well as research, but really you could have a little tablet or screen here that could put in a number of measures such as pressure waveforms, your oxygen saturation curves, or your EEG or NIRS values if you wanted to do that as well as some additional equipment up top. But it's important, and I'll talk about this at the end, in terms of how your team integrates all this information during use. So the way I divided this talk up, and again, I'll go fairly quickly for the sake of time, is just different organ systems. So, we start with the heart for cardiac monitoring, and mostly because not that the heart is the most critical organ as far as being injured, but it gives us a surrogate of how well the resuscitation is going. And we all know this data that these recommendations that ILCOR is recommending the use of ECG. So this isn't necessarily coming from a new research study, but the idea that you can get early access to a heart rate and it's more reliable than pulse oximetry. There have been a number of studies done by our group and others that have tried to see if you could see a difference in interventions when you have ECG or not. And really, when you look at them, none of them have borne out any clinical differences. And really that comes down to the team is doing multiple things to try to assess heart rate in these babies. They're auscultating, they're palpating, they're assessing other modalities to then try to initiate ventilation or other things. But the technology has slowly been improving, where now we're getting a heart rate faster, even in just using standard ECG leads alone, but newer rapid algorithms from a paper we just published this year to this newer device, and it looks almost like one of those Fitbits that you put around the baby's chest called a NeoBeat. And this has been really useful because of newer ways of how we're resuscitating babies, to the point now we're actually getting heart rate data while the cord is still intact. This is a study done by a group in Europe looking at over 900 babies that had delayed cord clamping and looking at heart rate percentiles over the sort of first 5 minutes of life. And I think the idea of using some sort of way to gauge heart rate during delayed cord clamping becomes really unique when you're now starting to look at things such as resuscitating babies while the cord is still intact. So I have a brief video here, just a few second clip of a baby that we did delayed cord clamping on. So I'll turn the volume down. And you can see as we're wrapping up, you can see the heart rate digitally displayed here. And the resuscitation can be performed while the cord is connected. And then the baby can be stabilized with ventilation as needed. So this can be a futuristic tool for us, but quite simple to implement into an OR or something when you're trying to evaluate heart rate in these newborn infants. Another modality is something known as electrical cardiometry, where you measure changes in RV cell movement to then be able to calculate a stroke volume or cardiac output. And we did an initial pilot study on healthy term babies, looking at the changes in stroke volume and cardiac output, showing that for every minute the baby is connected to the cord, the cardiac output increases and the stroke volume by 13% per minute. And this could be a modality then again assessing that if the baby's transitioning well, or do they need sort of other interventions. Again, sort of moving again along with the heart, looking at other modalities such as blood pressure. This is not a delivery room study per se, but it highlights the importance by this group in Austria of measuring blood pressure early. This group looked at not only blood pressure in the first 10 minutes, but then they looked at comparator groups that developed IVH or not. And you can see here that the blood pressure was statistically lower, even as early as 25 minutes after birth in those babies that developed severe IVH. Whereas the most of us will measure our first blood pressure maybe an hour or two when we finally transduce that umbilical arterial line or do a cuff pressure. There could be potential benefit in measuring blood pressure in the delivery room. Now you might say, well, doing cuff pressures aren't very reliable. Well, this group at Stanford has recently looked at measuring non-invasively arterial pulse waveforms that are as accurate as an indwelling arterial catheter. Again, this is a really small sample size of only 16 babies, but they are exploring, and we're looking at doing this in our own delivery rooms to see whether or not we can measure the pulse waveform as well as in continuous blood pressure in these babies as soon after birth. So this could be a very simple, non-invasive method. You could just use one of the feet and place this sensor on a few minutes after birth. So moving from the heart now to the brain, which is obviously the organ we probably care the most about maintaining normal oxygenation and perfusion, that neuromonitoring can be done quite easily at birth. And this is a video clip of a fairly healthy 30-weeker that we did monitoring. I'll just turn this down here, but you can see here as they're resuscitating the baby, putting a face mask on, you have your EEG over here, which is a very limited montage, and your NIRS probe here. And you can embed these two in a sort of a headband where you can place it fairly quickly while the baby's still getting other measures. So you can see as they're checking the heart and lungs, putting on a pulse oximeter, you can then, you'll see here in a few seconds, put a NIRS band on the baby's head without interrupting resuscitation, and actually getting values fairly quickly after birth. And then there's the NIRS band being placed on the head, and almost instantly you start seeing EEG waveforms as well as a NIRS value within a few seconds after. And what's remarkable is how much faster a NIRS value can appear because of its use of venous oxygen saturations compared to even a pulse oximeter. Now, NIRS has been studied by a number of other groups. This is some early data by the group in Ulm that demonstrated that these two babies that developed a grade 2 and grade 4 IVH had lower NIRS values than their normative data. And really, Germany and Austria have led the way and started developing normative data in the first few minutes of life. This other very nice study done by the group in Cork also demonstrated that babies that needed a high amount of oxygen actually had very low cerebral oxygen saturations in the first few minutes of life, compared to the babies that transitioned quite well. Another study, again, done by the group in Austria that were near-term infants demonstrated that these babies that needed resuscitation actually had not only lower NIRS, but in the first minute or two had a lower EEG voltages in the first 3 to 4 minutes. So there is something about cerebral hypoxia that we're able to detect fairly early in these infants. We also did a large study in smaller babies comparing EEG and NIRS to see the predictive value of IVH. Our setup was very different than the group in Cork that used a full montage. They're very good at doing full EEGs, but you can see here the challenges of placing EEGs on an infant. It is quite tedious, and you definitely need to have additional staff support to do this. So our setup was a little bit different in that we placed the EEG, a 3-channel EEG with it embedded into a NIRS band onto the infant's forehead. And what we found in this study of 130 infants is that none of the parameters were significantly different in those infants that developed severe IVH or death, except for their NIRS values. And it wasn't right after birth. It was around 7 minutes of life that we saw this separation of babies that, as you can see in the dotted line, those infants that developed severe IVH or death never got their NIRS up to a certain cut point. And when you sort of blow that one line up, you can see that as shown here, the babies in yellow, that if your NIRS never reached above 66, these babies had a high sensitivity and specificity to develop severe IVH or death. So this is a good potential predictive tool, but then the next natural question comes, what to do with it? And again, the group in Austria has recently completed this trial. I don't have the data to date. I think they'll be presenting it soon, but looking at the integration of NIRS in addition to pulse oximetry to then co-manage oxygen management and ventilation in these babies to see if they could reduce death or neurological injury at 2 years of age. And they have quite a convoluted flow chart here, but really what it comes down to is that the oxygen saturations are within normal range. Then you look at the NIRS values, and then if those are out of range, either too high or too low, you adjust up or down your oxygen levels, or increase or decrease the need for positive pressure ventilation. And then every 60 seconds you're reevaluating them. And the way this group has, since they've published so much on normative NIRS data, you can see here they have these same sort of oxygen curves for NIRS as you would pulse oximetry. So I think more to come. CosGod will really guide us if we should start bringing NIRS into our delivery room, but it's definitely a useful tool to be using for brain monitoring. All right. Now we're going to move into lungs and looking at respiratory function monitoring. One of the reasons this seems so attractive is that in the delivery room, you're essentially using a manometer. So something very archaic, you're squeezing the bag, or nowadays we're just hitting a little T-piece and looking at the pressure. We have no idea what's happening into the lungs of the babies. And then 10 minutes later, the baby then gets hooked up to a beautiful ventilator. It could be any one of these, but essentially you're getting beautiful pressure waveforms, you're assessing leak, tidal volumes. And so it seems sort of silly that we do it so archaic at birth, and then we move into this nice technology into the NICU. So why can't we integrate the two? And that's really where RFM comes into play. And one of the pioneers of this is George Schmelzer at the University of Alberta, who's done some really nice work, and these are some tracings he's loaned me, but looking at how the ability you can detect not only the breaths you're delivering, but actually what the flow is into the baby. So you can see whether or not air exchange is actually occurring. And this is their screen setup that they use in their delivery room currently. One of the initial studies that they demonstrated was a blinded, non-blinded trial with RFM, and demonstrating that if you have RFM visible, you were able to reduce the percentage of mass leaking in these infants. And then there were a number of outcomes that were improved as well, such as improved use of CPAP, decreased need for intubation, and a decreased need for oxygen administration. So you're obviously providing less support if you have RFM available, at least when done at this site in Canada. Now, a larger RCT was done by Ian Tapas's group in Leiden, where they looked at close to 300 babies. The primary outcome was looking at the target of achieving a 4 to 8 milliliter per kilo tidal volume in this group, but they obviously looked at a number of secondary outcomes as well. But unfortunately, in this trial, really the two groups converge, whether the RFM was visible or not. The average tidal volume tended to be identical, and really there were no differences in their secondary outcomes for the most part. And so one of the challenges is that if your team has RFM available, do they actually get better whether or not they're using the RFM or not? And this is one of the things that came up in this. But still intuitively, just like ECG, sounds like a good tool to have because you're able to integrate a number of other factors. Some other areas I just wanted to briefly touch on was oxygen saturation monitoring. It's important to remember that all the curves we're using based on this original data by Dawson et al. Really only used a few babies that were under 32 weeks, about 38 kids. So even though the overall sample size was robust, because you had to use babies that did not require resuscitation, you have to take this with sort of grain of salt. We don't really know the ideal oxygen saturations for babies that are this small. And so one of the things that's come up with in these RCTs, such as this one by Julie Wee, that demonstrate that babies that had started on 21% versus 100%, the babies that started on low amounts of oxygen or none actually had more death that were under 28 weeks. And so we're still trying to figure out what is the right oxygen target for these infants. This same group has done meta-analysis with some of the other investigators over the US and Europe, and has demonstrated that in all of these trials done out of studies in Spain and Norway and the United States, that when they combined their data, babies that had oxygen saturations of less than 80% were more likely to die and have severe IVH. And this is a problem because we haven't quite figured out the right initial starting point for these infants. Our group has also done the same thing in a number of our cord clamping studies, and we've demonstrated that in the first few minutes, even if you provide higher levels of oxygen, as shown here in the black line, compared to the babies who had low oxygen, normal oxygen saturations, you really don't seem to reduce the incidence of severe IVH or death. So all of these infants that still continue to have low oxygen saturations, it doesn't seem that being more aggressive or providing more support seems to do anything. It might come down to how high we start on these infants. One potential tool, it's not really a monitor you can purchase, but something you can just develop yourself. Wade Rich, one of our coordinators, is basically taken data that's being streamed in from the oximeter and the blender and plotted it on an Excel sheet that could be graphically displayed. So you could really target your oxygen saturations by trying to go up a little faster or slower based on whether you're in these normal targets. And we've been able to show that having this targeted oxygen tracking system improves the time you spend within range. And these are just some other ongoing studies going on right now. Vishal Kapadia in Texas has done looking at different percentiles, 25th or 75th. And this pilot study was recently completed and demonstrated that you really need to aim to a higher target at 75% to reduce some of the morbidity that we might be seeing in these babies, such as bradycardia, oxidative stress, and respiratory support. So he's now doing a larger RCT that's going to look at over 700 babies that are randomized to a higher oxygen saturation curve compared to this lower number. So hopefully more to come in terms of what target range to pick. Meanwhile, as far as starting on different oxygen levels, Julie Wee's doing an additional trial looking at starting at 60% versus 30%, 21%, sorry, and then seeing whether or not we improve survival without disability. So again, this may play into what oxygen level we start with. And then the last thing I wanted to show you before I wrap up here is this really neat technology that's being worked on by the group in Australia. And you can see here that we don't really have an idea of lung volumes as far as visualizing it. And there's this technology known as electrical impedance tomography, mostly used in adults on ventilators, so you can be able to look at changes in lung volume and expiratory lung volume, changes in compliance. But if you could apply to a baby in the delivery room, now this is a healthy newborn that's not needing any resuscitation, but as you can see over time that once the belt is placed, you can then be able to look at these changes in lung volume over time and seeing whether it's expanded or not. And one sort of idea I see in the future is this could help us guide whether or not we're over-ventilating the lung and we need to back down to avoid things like pneumothoraces, or our lung is still collapsed and we need to be able to increase our PEEP or other maneuvers. So hopefully more to come with that. And so the last thing I just wanted to say as I wrap up is that while we know that these monitors are all great and we're getting a lot more information, I think we know that this is going to be better than just using simple things like chest rise and color change in the baby. The flip side of this is balancing the load on the team. And when we look at human factors research and integrating into these trials to see what's that tipping point where you're getting good information, improving resuscitation of the baby, but not overloading the team where they're now not looking at the infant or doing the right interventions because they're overloaded with data. So I think to wrap up is that we need more studies, but I think some of these technologies might be helpful. And I think I'll end it there. Thank you.
Thank you, Dr. Khateria. Our next speaker is Sharifa Habib. She's a neonatal nurse practitioner in the NICU at Sick Kids. She has a particular interest in caring for neonates with hemodynamic instability and preterm infants with congenital heart disease. Her current focus is on collaboration between cardiology and neonatology and optimizing the care for this at-risk population. Her talk is titled Anticipating Cardiopulmonary Decompensation.
Thanks, Jenny.
Good morning and welcome to our session on anticipating cardiopulmonary decompensation in the neonate.
I have no financial relationships or conflicts of interest to disclose to you. The objectives for our session today are really to start to understand the nuances in neonatal physiology and anatomy that impact hemodynamics, to evaluate some common methods of clinical assessment and understand their utility and reliability, and then to identify patterns and changes that really indicate that there's impending cardiopulmonary compromise. We have all seen that patient. You walk into the room, you see a mottled or pale, sometimes even gray infant in respiratory distress who looks lethargic, globally unwell, and we wonder how we got to that point. Case reviews often let us go back in time and see the preceding signs that we missed more clearly. Let's take a step back and consider the assessments we perform on a daily basis and what we can glean from a more critical appraisal of some of these basic parameters.
We can consider 4 different aspects of assessment, so we can think about the clinical context in which our patient exists, biochemical evaluation such as lab work, diagnostics, and of course physical examination. And we're going to spend a fair bit of time talking about physical examination and what we actually see at the bedside. Most clinicians will rely on blood pressure, heart rate, urine output, and capillary refill time, as well as maybe serum lactate to determine stability and the adequacy of oxygenation and cardiac output. It's important to discuss each individual parameter and how reliable or useful they are. Capillary refill time, for example, is very easy to utilize, but you can't use it in isolation. Heart rate, as we'll talk about, is a very important parameter for us to look at, and an elevated heart rate is often seen as compensation for low cardiac output. We'll talk about blood pressure and its reliability at predicting adequate perfusion. And of course, a lactate can be a very useful indicator, but it can also reflect situations in which you may have hypoxia, as well as other conditions such as metabolic disorders, inadequate liver or kidney clearance, and an isolated lactate does not predict poor circulation. Urine output, of course, can be variable and based on age, so we know that we have an initial anuric phase followed by usual natural diuresis and polyuria. Other tools that we haven't yet talked about are those such as echocardiography, of course, and Dr. Castaldo is going to talk to us later in the sessions about TNE and its application and utility in the NICU.
Capillary refill. We use this as a quick and regular assessment. I don't think any bedside clinician examines a patient without doing this. It's ingrained. We use this to tell us about perfusion or oxygen delivery. This is essential, of course, to meet metabolic needs and support cellular function. Prolonged impaired perfusion leads to organ dysfunction, energy failure, and cell death. In at-risk populations, such as preterm infants with pressure-passive circulation, this hypoperfusion can contribute to the development of IVH, white matter injury, and long-term sequelae of these same. However, if we reflect that we are ultimately using this tool to tell us about the adequacy of systemic perfusion, it's important to recognize that superior vena cava flow, indicating venous return from the brain and upper body, is very poorly correlated with capillary refill time, especially when we consider it in isolation. So we may start to question how and why we use this. It's also important to remember that tissue perfusion depends on respiratory and cardiac function, hemoglobin, and systemic resistance. We can consider some studies that have looked at capillary refill time. One study found that a cap refill greater than or equal to 3 seconds only had a 55% sensitivity and 81% specificity of predicting low systemic blood flow. Another study found that when you combined a capillary refill time greater than 3 seconds with a mean blood pressure less than 30 millimeters of mercury, this increased the sensitivity of predicting low systemic blood flow to 78%. The most impressive findings are when you combine a lactate greater than 4 millimoles per liter with a capillary refill time of greater than 4 seconds, and this predicts a low systemic blood flow with 97% specificity. Most clinicians, however, would say by the time that you have a combination of a prolonged cap refill, elevated lactate, and low blood pressure, we already know that there is a failure to compensate and that additional supports are necessary. So what other parameters can we then evaluate to assess hemodynamic and cardiopulmonary stability? Before we consider these additional parameters, let's take a minute and think about the innate differences in the neonatal myocardium. Dr. Levy is going to provide a wonderful session on the neonatal myocardium, but for now, we'll briefly review some of the nuances and differences compared to an adult heart. We know that the neonatal heart is only about 30% contractile tissue compared to about 60% in an adult heart. This heart is therefore more fibrous and allows for less diastolic capacity. There are a reduced number of mitochondria or energy stores, and this renders the heart less able to cope with additional stressors. The architecture of the heart is overall still very immature, and we know that there's a decrease in calcium reserve within the sarcoplasmic reticulum, leading to a neonatal heart that's very dependent on extracellular calcium. So let's keep thinking about fundamentals. Dr. McNamara is going to give what I'm sure will be a wonderful talk on fundamentals, but let's start to consider some of the most simple principles and how they translate to what we see at the bedside and vice versa, how what we see at the bedside can inform what's actually happening. A German physiologist was working on myocardial contractions in frog hearts and helped to define the Frank-Starling law. This tells us that the force of a contraction is directly proportional to the initial resting length of the cardiac muscle fiber. So the longer the initial resting length, the stronger the contraction. There is, of course, a point at which, if you stretch beyond, you have a loss of tension and decreased contractility. The volume of blood in the heart is what causes stretch, and this changes the tension. Higher end diastolic volume leads to an increase in contractility and increased stroke volume, which translates to an increased cardiac output. That's the formula you see here. So why are we talking about this? We just talked about the innate differences in the neonatal heart, and that it's more fibrotic and less elastic. So when we think about the fact that cardiac output is equal to stroke volume times heart rate, we can understand that due to this increased fibrotic and non-elastic myocardial tissue, there is a limited ability to stretch. This means that while we must optimize stroke volume, you cannot support cardiac output by strictly increasing stroke volume in a neonatal heart, and that heart rate can be affected by cardiac filling and function, but ultimately heart rate variability is a very useful predictor for shock. A rise in heart rate should tell us that an effort is being made to increase cardiac output and compensate for limited stroke volume. So once we understand that, our focus should be on evaluating conditions that affect stroke volume, such as preload, contractility, and afterload. So if we think about the Frank-Starling law as it relates to end diastolic volume or preload, we can see that as preload increases, the force of the contraction at subsequently stroke volume is increased. This explains why ensuring adequate preload is essential to maintaining cardiac output. While volume isn't always necessary, we may not know where we sit on this curve. The myocyte sarcomere length may not be optimal enough to generate maximal contraction. So it's also then important to consider the length, tension, and force velocity relationships. So we talked about stroke volume as a component of cardiac output and why the neonatal heart may respond differently to preload, as discussed in the previous slide. But we should also then remember that preload, contractility, and afterload affect stroke volume. And the force-velocity relationship is important to consider, as this tells us about how stroke volume is affected by afterload. You can see here how we expect the adult heart to cope, and we already reviewed that the neonatal heart is different. So you can appreciate here the significant difference in tolerance of afterload of the neonatal heart, and more specifically, that the right ventricle and left ventricle have different tolerances to afterload. This is important to keep in mind as we move forward. As afterload increases, you see a more dramatic decline in stroke volume. All of this is really to help us understand that tachycardia is a neon flashing sign alerting us to insufficient cardiac output, and that we should be in tune to this and understand the underlying etiology to provide the appropriate interventions. If we consider parameters that are impacting preload, so is it PPHN with insufficient pulmonary flow leading to poor LV preload, or contractility, such as impaired contractility that we see in about a third of patients with HIE, or other conditions that are affecting afterload, again, alterations in pulmonary or systemic vascular resistance. All of these factors may lead to inadequate stroke volume, which may lead to compensatory tachycardia. I told you that we would spend some time talking about blood pressure. It's important for us to understand that each value, the systolic and diastolic, independently actually provides us with a lot of information about what's happening with our patient. The systolic actually represents contractile force and cardiac output of the left ventricle. So if we look at this number, it may inform us about low preload or poor contractility or high afterload. The diastolic value tells us about the resting pressure of blood within the vessels. This tells us about systemic vascular resistance. So a low diastolic value should force us to think about situations in which we may have vasodilations, such as inflammatory states, and also situations in which fetal shunts, such as a PDA, may be contributing. As simplistic as it sounds, ensuring that the data is accurate is an enormous part of clinical care. A cuff too large may result in difficulty obtaining a value or even an artificially lowered blood pressure, while a small cuff will falsely elevate it. Some basic troubleshooting can be really helpful. When we're lucky enough to have an invasive arterial blood pressure, it's usually reliable and accurate. The waveform, however, can also give us information about the quality of the reading. Is the waveform dampened? Perhaps there's a clot in the line, or the catheter tip is resting against the vessel. An abnormally high invasive blood pressure should lead us to think about the transducer. Where is it? A difference of 10 centimeters in height will increase the blood pressure by about 7.5 millimeters of mercury. So it's important that we keep the transducer at the level of the heart. Has the line accurately been zeroed? All of these things are important for us to consider. You can find many different tables that are either stratified by weight, postnatal age, or gestational age that provide you with percentile thresholds for blood pressure values. Take, for example, this table of third percentiles for gestational age. How do we know what percentile provides adequate perfusion? What about individual variability? Does the population from which this data is derived represent the neonate in front of you? If we were to say that hypotension is defined as a blood pressure less than the 5th to 10th percentile, in one observational study, they found that 50% of VLBW infants in the NICU would be described as hypotensive. If we use SVC flow as a marker, again, another study found that some VLBW infants in early life would have normal blood pressures, but low SVC flow. In fact, Martin Kluckau's group observed that 35% of VLBW infants had low SVC flow in the first 24 hours of life, but not all of these infants had numerical hypotension, although a large proportion of them went on to develop it. So, looking at blood pressure alone may not actually inform us of impending cardiopulmonary deterioration. The bottom line here is that numerical hypotension is too simple to predict compromised neurodevelopmental outcomes, and we still don't clearly know what this number would even be. But we know that the risk exists, so we have to intervene at some point. Numerical hypotension plus clinical correlates or signs of hypoperfusion are probably the best likely indication that intervention is required. So what if we abandon the idea of a numeric cutoff? What about a physiologic endpoint? Can we identify a threshold below which we believe cerebral perfusion may be compromised? Is it the same for other organs? Some time has been spent evaluating this idea of a critical mean, or the idea that below a certain threshold, say a mean arterial blood pressure of 28 to 30 millimeters of mercury, oxygen delivery may be compromised. Systemic hypotension has long been believed to be a significant risk factor for white matter injury and intraventricular hemorrhage. However, as many of you know, it is challenging to document this, and in part, this is related to variability in the definitions and monitoring. The idea that we're alluding to here is something called cerebral autoregulation. And while this isn't something that we can necessarily measure in the NICU, it's something that we need to have an awareness of. Autoregulation in this case refers to the ability to contract and dilate arteries with changes in pressure to maintain constant cerebral perfusion. In preterm infants, we believe that there's a very narrow range during which autoregulation can occur, and above or below this may result in significant changes in perfusion. This likely applies to ill neonates as well. The theory is that autoregulation may be lost at a mean arterial blood pressure somewhere below 28 millimeters of mercury. So there may be a change in cerebral blood flow below this. That doesn't necessarily mean that cerebral hypoxia occurs. There may be increased cerebral fractional oxygen extraction, microvascular dilation, and a maintenance of tissue oxygen delivery up until a point. Below this functional threshold, ischemia may occur. And perhaps this is why multiple studies have failed to show an association between low numerical blood pressure and poor neurodevelopmental outcomes.
The other piece of the puzzle is, of course, not just what is happening, but why. And if you know the why before the deterioration, you can anticipate how it may manifest. Of course, many disease processes may present with similar clinical findings, for example, hypotension. However, if we can understand the mechanism and underlying process, we can intervene in a targeted manner. When evaluating hypotension, we can consider three general categories of causality. The first is cardiac dysfunction, such as those caused by congenital heart disease, myocardial ischemia as in HIE, myocarditis, and situations that may increase afterload such as PPHN leading to RV dysfunction. These disorders may affect contractility and adversely impact cardiac output. The second category is hypovolemia-related hypotension, in which there's a decreased preload leading to an inability to maintain cardiac output. Hypovolemic shock is most common in a neonate, but most VLBW babies that are hypotensive are not hypovolemic. The history should support a cause for hypovolemia, such as fetal maternal hemorrhages, abruptions, birth injuries, coagulation disorders, dislodged arterial lines, or other causes of iatrogenic blood loss. Also, don't overlook volume loss in the setting of GI abnormalities. Also consider distributive losses, such as those that occur in sepsis with third spacing. The last category is hormonal dysfunction. Very basically, we can think of this as a failure to mount a sufficient cortisol response to stress given the immaturity of the adrenal glands. So far, we've talked about lots of parameters and why they may or may not be reliable. So it's interesting to think about newer technology that we're seeing in the NICU that may be useful, such as near-infrared spectroscopy. And this provides a non-invasive measure of regional, cerebral, and somatic oxygenation. You can calculate tissue saturation and reflect a ratio of arterial to venous flow, and look at simultaneous evaluation of both cerebral and somatic saturation. This may tell us about hemodynamic stability, as hemodynamic compromise is usually reflected first in the reduced somatic oxygenation prior to changes in cerebral oxygenation. I'd be interested to hear how many of you are using this regularly in your units. One of the last indicators of instability for us to discuss is thermoregulation. We diligently monitor infant temperatures, set neutral thermal environmental temperatures on our isolates, flag hypothermia as early signs of sepsis, but we also need to talk about the importance of maintaining an NTE and the significant impact that impaired homeostasis can have on hemodynamics. So what happens when a baby gets cold? Maybe due to sepsis or a failure to maintain an adequate NTE, the first response is actually for the peripheries to cool and try and maintain core temperature. Symptoms of cold stress such as bradycardia, tachypnea, apnea, CNS depression, and others are shared symptoms of many other neonatal physiologies and need to be recognized. With inadequate brown fat to use for thermogenesis, a process that needs both oxygen and glucose, and in situations of impaired oxygen delivery, the basic cell metabolism, which operates on the oxygen-dependent citric acid cycle, ceases, and the body converts to anaerobic metabolism. This cycle leads to the accumulation of lactic acid and leads to the worsening of metabolic acidosis and the associated cardiopulmonary effects such as vasoconstriction, increase in pulmonary vascular resistance, and the subsequent impact on both preload and afterload. With peripheral vasoconstriction and pulmonary vasoconstriction, the heart now exists in a climate of increased afterload. Temperature instability should be a major warning sign of impending deterioration and the need to provide support and stabilize. So far, we've discussed many common parameters to assess hemodynamics. We didn't discuss echo, but there will be a lot of opportunity over the coming sessions to understand its significant utility. I hope you would agree that each commonly used clinical assessment offers some insight, but that no single variable provides the full picture. What is essential to understand is that commonly used vital signs such as heart rate and blood pressure are dependent variables, relying on aspects such as cardiac output, which reflects preload, contractility, afterload, and stroke volume. And all of this is occurring in the unique anatomy of the neonatal heart. The last important point here is that understanding the pathophysiology of the conditions that are unfolding should help us understand what types of decompensations to anticipate. We've spent a lot of time talking about hemodynamics, but of course, pulmonary deterioration is a common occurrence in the neonate. Dr. Wise is going to present on cardiopulmonary interactions, and I'm sure this will bring it all together. In some ways, respiratory deterioration is just easier to see and understand. The clinical symptoms are more readily assessed, such as work of breathing, tachypnea, hypercarbia, and alterations in PaO2 and saturations. So we can start to anticipate deterioration by understanding risk factors for respiratory compromise. Many of these details will be easily identified in the antenatal record. The list presented here is of course not exhaustive, but these common risk factors have predictable respiratory consequences.
We know that factors that impede pulmonary circulation will translate to an impact on systemic circulation with a reduction in left preload. We can also predict situations in which disease processes may lead to high right ventricular afterload and cause RV dysfunction, increased myocardial wall stress, and possibly compromise coronary artery perfusion. Not listed here are other acute processes such as tension pneumothorax that can have dramatic impact on hemodynamics, but once recognized and addressed can be readily ameliorated. Other conditions may have a more prolonged impact on cardiopulmonary status, such as meconium aspiration syndrome and certainly RDS in the premature infant. The goals of respiratory stabilization and intervention are really to provide adequate oxygen and ventilation and avoid hypercarbia, which may reduce cerebral blood flow, and also avoid hyperinflation, which may impede venous return. We need to consider the underlying cause and address hypoxemia and acidosis. We need to maintain normal targets in the absence of other contributing factors, such as congenital heart disease. Sometimes we just can't see the forest for the trees. The volume of data available in the ICU setting can sometimes be overwhelming. Often when something dramatic occurs, we are forced to evaluate the etiology and causality in retrospect. Sometimes being able to stand back and observe trends and deviations from patient baselines or norms may actually allow us to identify subtle changes that are evolving over time. Maybe we're going to identify a lack of variability or gradual changes in certain parameters. So why is this important? It may alert you to the compensatory mechanisms that over time may not be able to sustain themselves and are now failing. It may also allow for more timely intervention. The goal is to identify deterioration before it happens, to intervene early and stabilize cardiac output and oxygen delivery in order to prevent shock. So how do we do this? What are we evaluating? These are all the things we've spent our time talking about. We look for changes in lab values, respiratory status or requirements, perfusion, and organ function. Continuous plotting of multiple hemodynamic parameters over time may be a very useful way to determine the response to an intervention as well. This is where data integration and visualization software comes into play and is really exciting and I think the way of the future. This allows us to look at a massive amount of data through a variety of monitors that are used in clinical care, and there's an opportunity to apply technology to analyze this data and predict patient events. One such example is the T3 software program. This allows you to track patient data, identify patient trajectories, and trigger clinical decision-making. It can allow you to create patient-specific thresholds, which can be really useful. Our goal is really precision at the bedside. We need to consider the clinical context and anticipate changes, to watch for subtle changes that fit the expected pathophysiology, and to utilize all available data points and ways of knowing. This allows us to provide early intervention.
Thanks, I went a couple minutes over.
Thank you, Sharifa. Our next presenter is Michelle Bazinski. She is the Respiratory Therapy Practice Lead for the Women and Infants Health Program at Mount Sinai Hospital. She is currently completing her Master of Science in clinical epidemiology and healthcare research at University of Toronto. And her specific research interests include pulmonary vascular disease and respiratory disorders associated with prematurity. She is presenting ventilation perfusion matching.
There we go. Okay, great. Thank you so much for the introduction. You guys can see my slides okay? Yeah, okay, great. All right, so I'll just do a quick shout out because it's RT week. So if there's any RTs on the call, happy RT week to you. If you're not an RT, please reach out to one and wish them a happy RT week. So the goal of today's presentation is to provide a refresher of VQ matching and offer you some food for thought as to how we can apply this concept to your approach to ventilation management. I have no disclosures. So the ability of the lungs to efficiently deliver oxygen from the environment to the blood depends critically on the matched delivery of oxygen-rich air and deoxygenated blood at the site of gas exchange. So in other words, the efficiency of gas exchange depends on matching of ventilation and perfusion across the alveolar capillary membrane and can be generally represented by a VQ ratio. The VQ ratio typically represents the efficiency of gas exchange overall, at the extremes of which are alveoli with no ventilation but adequate perfusion, and those with adequate ventilation and no perfusion. So with this brief introduction in mind, the objectives of my talk today are to first review gas exchange and the factors which influence the rate of diffusion. Also talk a little bit about the determinants of ventilation perfusion, including defining shunt and dead space, as well as reviewing west zones of the lung, and finally putting it all together with the concept of VQ matching. So starting with gas exchange and diffusion. So we understand that the primary purpose of ventilation is for gas exchange. So very, very basic review or overview of gas exchange physiology is that, simply stated, molecules of carbon dioxide and oxygen move across the AC membrane via passive diffusion, following a gradient from high concentration to low concentration. The AC membrane is a thin barrier between the alveolus and the capillaries, which is comprised of alveolar epithelial cells and capillary endothelial cells, and separated by an interstitial space. The AC membrane has two important functions, that is, to prevent the movement of fluid from the capillary into the interstitial space, as well as into the alveolar space. Now, a healthy epithelium is impermeable to protein. However, if it's damaged, it can result in the movement of fluid into the alveolar space, which can cause surfactant deactivation, promote the inflammatory cascade, which is often associated with acute respiratory failure, and of course, impair gas exchange to varying degrees. So in terms of the specific factors which can affect the rate of gas diffusion, this can be best represented by the following equation, where the rate of diffusion equals pressure, temperature, and cross-sectional area over molecular weight and distance. So just thinking about ways in which we can augment the rate of diffusion. So first we can start with pressure and temperature. So if you increase the pressure or temperature of a gas, it will increase the rate of diffusion across the membrane. Also, if more alveoli are participating in gas exchange, i.e. Having an increased cross-sectional area, this will also increase the rate of diffusion. Conversely, ventilating with heavier particles decreases the rate of diffusion. So a practical example of this would be using nitrogen versus helium, and also the further distance particles have to travel will also decrease the rate of diffusion. So thinking about hyaline membranes or interstitial edema, for example. And although the solubility of gas is not specifically mentioned here, recall that molecules of carbon dioxide are 20 times more soluble in water than oxygen, and therefore move more readily across the AC membrane. So with that understanding, understanding that ventilation is a precursor to gas exchange, it's important to understand the factors which can affect regional ventilation. So here we're talking specifically about alveolar ventilation, or the portion of ventilation participating in gas exchange. So we'll start with the effect of gravity, that is the direct transmission of weight on the lung. This includes the weight of the lung itself, which is influenced by factors such as lung density and edema, the weight of the heart and all the large vessels contained within the mediastinum, and the weight of abdominal contents, which in certain pathological conditions such as neck or SIP, for example, can cause an increase in intra-abdominal pressure. And with the increased weight or pressure on the lung, the net distending pressure transmitted by the ventilator to distend the alveoli is relatively less, resulting in an overall decrease in recruitment and ventilation. The next factor is posture, which changes the effect of gravity through the shifting of these internal organs and their respective weight. So turning a patient prone, for example, eliminates most of the weight of the heart on the lung and the weight of the lung itself, and as such has the potential to increase ventilation. The next factor is anatomical expansion potential, which essentially describes the influence of the anatomical structures on ventilation. So if you think about the lung bases relative to the apices, they have more room to expand and therefore have a greater potential to change their shape and augment ventilation. And this is because the chest cavity in the apices is relatively fixed, whereas at the base of the lungs, the diaphragm expands down and the rib cage expands outwards. Which brings us to the next factor, which is lung compliance, a property which describes the ease with which the lung can expand and is represented by a change in volume over given pressure applied. In the bases of the lung, alveoli are relatively deflated and are therefore more compliant as compared to alveoli in the apices, which are almost already fully inflated. Having said that, in areas of consolidation, inflammation, or atelectasis, there will be decreased compliance and decreased ventilation as well. And the last factor is breathing pattern, which can influence the distribution of ventilation through changes in expansion of either chest wall or the diaphragm. The other important component of gas exchange is perfusion. And so here we have listed a number of factors which affect regional pulmonary blood flow. The first factor is lung volume. So it's important to remember that pulmonary vascular resistance is lowest at functional residual capacity, or FRC, when the lung is adequately expanded. If the lung is collapsed, this in turn causes blood vessels to become twisted and kinked. And if it's hyperinflated, causes them to be compressed, which in both cases will cause an increase in PVR. The next factor is hypoxic pulmonary vasoconstriction, which is a mechanism intrinsic to the pulmonary vasculature, whereby intrapulmonary arteries constrict in response to alveolar hypoxia. In doing so, it diverts blood from poorly ventilated areas to better ones, improving VQ matching and gas exchange. I'll show some examples of this later on. The next factor is gravity, which was also listed as a determinant of ventilation, but in this case refers to the hydrostatic pressure exerted on the capillaries lowest in the pulmonary vascular bed. So for example, in a patient who is upright, the blood volume would be most at the base of the lung. And the last factor is anatomical structure of the blood vessels themselves, which can impact the direction of blood flow unrelated to oxygenation, gravity, or posture. And within this category could also be the effect of pulmonary vascular remodeling or impaired pulmonary vasculogenesis, commonly associated with chronic lung disease, both which can have deleterious effects on perfusion. So now when we talk about determinants of ventilation and perfusion, we would be remiss not to discuss the terms dead space and shunt. So we'll start with dead space, which simply describes the portion of total ventilation that does not participate in gas exchange. And when referring to dead space, it can be further subcategorized as physiological dead space, that is comprised of both anatomical and alveolar, and mechanical or apparatus dead space, which is dead space contributed by things like the ventilator circuit, endotracheal tube, and various measurement devices such as flow sensors and capnometry. Anatomical dead space refers to the anatomical structures which conduct air from the mouth opening to the terminal bronchioles, and for most individuals is approximately 2 mils per kilo of ideal body weight in volume. Alveolar dead space refers to alveoli which are filled with air but do not participate in gas exchange owing to a complete lack of pulmonary capillary blood flow. In terms of the consequences of increased dead space on gas exchange, it is essentially the same effect as would be expected if you were to decrease ventilation. Both CO2 clearance and oxygenation would decrease. As dead space increases, the efficiency of ventilation is decreased, and as a compensatory mechanism, you may observe your patient having increased work of breathing. So it's important to consider fixed anatomical and mechanical dead space in your ventilation strategy. So taking effort to reduce mechanical dead space by reducing length of your circuit or humidifier capacity, considering a tracheostomy in older ventilator-dependent patients, and removing flow sensors or end-tidal CO2 monitoring if feasible and does not impair synchronicity of ventilation. The next term is shunt, which refers to the portion of cardiac output which enters the left side of the heart and systemic circulation without participating in gas exchange, and is comprised of two components, anatomical and intrapulmonary shunt. Now, anatomical shunt is comprised of physiological and in some cases pathological shunt. The former includes drainage from bronchial, pleural, and Thebesian veins, which bypass the lung. And the latter includes conditions such as congenital heart diseases with a right to left shunt or an intrapulmonary arteriovenous connection. And now the normal range of shunt in a healthy individual is typically 2 to 5% of cardiac output. So intrapulmonary shunt is when blood enters the pulmonary capillary bed, bypassing through capillaries, but not participating in gas exchange. Now, shunt can occur for a number of reasons, such as small airway occlusion, pulmonary edema, consolidation, atelectasis, or in some cases due to excessive capillary blood flow. And shunts can be described as absolute or true, or shunt-like states. Absolute shunt is when there is capillary blood flow, but absolutely no ventilation, which would be represented by a VQ ratio of 0. And shunt-like states are when the capillary blood flow does not equilibrate completely with alveolar gas, and this would be represented by a VQ ratio less than 1 but greater than 0. Intrapulmonary shunt can also be represented as a fraction of the cardiac output, which was referred to as shunt fraction. So in healthy individuals, this represents less than 10% of total cardiac output, and an increasing shunt fraction would indicate worsening of intrapulmonary shunt, for which the primary consequences is a decrease in oxygenation. So if the shunt fraction exceeds 50% of cardiac output, increasing FiO2 will no longer improve arterial oxygenation. I'll use some simple illustrations in the next slides to demonstrate this point. So in addition to prompt treatment of the underlying condition, this type of scenario requires immediate strategies to optimize alveolar recruitment and pulmonary blood flow, and increase pulmonary blood flow. And in terms of CO2, shunt actually has little effect on CO2 clearance, and the reason being that an increase in alveolar ventilation as a compensatory mechanism is often sufficient to manage CO2. So here are the illustrations. So in the first scenario, we have two functional lung units receiving deoxygenated blood, which is returning from systemic circulation in equal proportion of the total cardiac output. The saturation of deoxygenated blood returning from the body is, let's say, 70%. And with both units functioning normally, they would fully return oxygenated blood at 95% saturation, ready to be pumped out to the systemic circulation. Now, let's say, for instance, that we have the same two lung units receiving deoxygenated blood in equal proportion again, but this time there is a 50% intrapulmonary shunt. That is, only one unit is participating in gas exchange. Oxygen would diffuse from the functional unit to give us an oxygen saturation of 95%, and the other unit, which is not ventilated, would return the same deoxygenated blood at 70% saturation. Now, because the total blood volume returning from each lung unit is equal, we can take the average of both, 95 and 70%, which would give us an oxygen saturation of 82.5%. Now, for the same two lung units, we'll deliver an FiO2 of 1. So we would have the same oxygen saturation of 70 returning from the body, being received in equal proportion by both lung units. This time, the functional unit returns an oxygen saturation of 100%. Because we've increased the FiO2 to 1, but the other unit with no ventilation still returns 70. And therefore, the average of both units gives us an oxygen saturation of 85%. So despite an oxygen or an FiO2 of 1, there was very little improvement in oxygen saturation. And clinically, you are dealing with a large intrapulmonary shunt. And furthermore, in spite of less oxygen being delivered to the tissues, the oxygen extracted by the tissues is the same and sometimes more. So imagine what would happen to the oxygen saturation returning from the body. It would be less and less each time, resulting in lower and lower oxygen saturation returning to systemic circulation. So let's consider a fourth scenario where, again, there are two lung units, but this time more of the deoxygenated blood is diverted towards the lung unit that is better ventilated. So now, instead of deoxygenated blood flowing in equal proportion to both units, let's say there's only 25% of cardiac output flowing past the non-functional unit and 75% to the better ventilated unit. The oxygen saturation from the better ventilated unit is 95%, and it's still 70% from the non-functional unit. But because only a quarter of the blood volume was sent there, the combined oxygen saturation that will go on to systemic circulation is 89%. So this simple scenario illustrates the concept of hypoxic pulmonary vasoconstriction. So this is a useful mechanism for maintaining efficiency of gas exchange, which is intrinsic to the pulmonary vasculature. The intrapulmonary arteries constrict in response to alveolar hypoxia, which diverts blood to better oxygenated lung units and optimizing VQ matching and systemic oxygen delivery. When hypoxic pulmonary vasoconstriction is impaired due to disease or other factors, it may increase shunt and promote systemic hypoxemia. So now that we've covered shunt and dead space, let's explore the relationship between alveolar ventilation, perfusion, and interstitial pressure as it relates to different regions in the lung in relation to gravity. So in other words, the west zones of the lung. And these were derived by animal experiments which helped to determine that there was a vertical gradient of perfusion, and that on the basis of its perfusion, the lung could be divided into 3 discrete areas. A fourth one was added later on. So the apices of the lung are anatomically higher than the heart due to gravity, perfusion is reduced, and even more so due to relative overexpansion of alveoli in comparison to the bases. In an upright individual, gravity provides a normal gradient of blood flow from the apices to the bases of the lung, with the bases receiving substantially greater flow than the apices. So we'll break this down into zones. So starting with zone 1, which is typically not observed in the healthy human lung, the pulmonary alveolar pressure exceeds arterial pressure in all parts of zone 1. And this is generally only observed when a person is ventilated with positive pressure ventilation or has a significant hypotension. In these circumstances, blood vessels can become completely collapsed by alveolar pressure, and blood does not flow through these regions, becoming alveolar dead space. And in some cases, blood flow is limited and may be cyclical, that is only during systole, and depending on the phase of respiratory cycle. Because of these conditions, little gas exchange takes place. And in the case of alveolar pressure exceeding arterial pressure due to positive pressure ventilation, one could take effort to try to expedite extubation. And if that is not possible, decreasing mean airway pressure to the lowest effective pressure to maintain oxygenation. And in the case of hypotension, volume replacement may improve zone 1 physiology. The next is zone 2. This is where alveolar pressure exceeds arterial pressure, but only for some of the time. Arterial pressure has to build up before eventually exceeding alveolar pressure, and then the blood flow can come through. And because of that, the blood flows in pulses, and this pattern is sometimes referred to as the waterfall effect. The next is zone 3, which comprises the majority of the lungs in health, where the majority of blood volume goes during gas exchange. Blood flow is continuous throughout the cardiac cycle. Both pulmonary arterial and pulmonary venous pressure exceed alveolar pressure, and therefore blood flow is continuous. It is proportional to the gradient between pulmonary arterial and venous pressure, and so the alveolar pressure does not play much of a role in true zone 3 physiology. And the last is zone 3, and here is where pulmonary arterial, interstitial, and pulmonary venous pressure all exceed alveolar pressure. This is the bulk of this zone is the bulk of atelectatic or edematous lung at the very base of the chest cavity, where interstitial pressure is highest due to the weight of the lung, exceeding pulmonary venous pressure. And as a result, blood flow is governed by the gradient between arterial and interstitial pressure, whereby an increase in interstitial pressure reduces blood flow. So now that we have reviewed all of the fundamental concepts relevant to ventilation and perfusion, we can now turn our attention toward the concept of VQ matching itself, which we defined earlier as the coordination of oxygen-rich air and deoxygenated capillary blood flow in a lung unit. So to simplify this concept, you can categorize VQ matching into 3 broad patterns. The first is a VQ equal to 1, which represents a lung unit with sufficient ventilation and adequate perfusion. Most simply stated that for every unit of gas, there's a unit of blood. In actuality, the VQ ratio of a healthy individual is somewhere between 0.8 and 0.9. That is slightly more perfusion than ventilation overall. The next pattern is a VQ less than 1, which represents lung units with less ventilation than blood flow. And this is a shunt pattern, which would most likely be observed in the bases of the lung. And the last pattern is a VQ greater than 1, which represents more ventilation than blood flow. This dead space pattern is mostly observed in the apices of the lung. And the last sort of term I just wanted to familiarize you with is VQ scatter, which describes the distribution of VQ ratios as a range in the lung as a whole, and can range anywhere from 0.6 to 3. This is VQ scatter represented graphically. Sorry, I'm just gonna move that up. Where we have ventilation and blood flows on the left y-axis, the different regions of the lung spanning from the bases to the apices represented on the x-axis, and VQ ratio on the y-axis on the right. So at the base of the lung, the blood flow is relatively higher than ventilation owing to gravity in an upright posture, and thus VQ ratio as represented by the black line at the bases would reflect a ratio less than 1, approximately 0.6. Now the VQ ratio reaches 1 around the 3rd rib in this graph before ventilation exceeds blood flow towards the apices, and the VQ ratio becomes greater than 1, around approximately 3. So this is the graphical representation of VQ scatter, so VQ anywhere between 0.6 to 3. And in general, the impact of VQ matching has the greatest effect on oxygenation and occurs in the VQ range increasing from 0.1 to 1, where a small change in VQ yields a significant improvement in oxygenation, while at the same time, the change in CO2 clearance is minimal. And so because CO2 and ventilation are closely linked, it's quite difficult to develop hypercapnia purely as a consequence of shunt and VQ mismatch. At the higher end of VQ ratios greater than 1, there is good ventilation, but decreased perfusion and little additional improvement in oxygenation. I'm almost done. I see your face, Emily. So in order to help us conceptualize this graph in the context of our NICU patients, let us review this graph again. But this time we have labeled the x-axis as dependent and non-dependent lung regions. So the dependent region is the lowest part of the lung in relation to gravity, usually with more ventilation potential and increased perfusion. And the non-dependent region is the highest part of the lung in relation to gravity, so relatively overinflated with decreased perfusion. So the one exception to the dependent lung region having more ventilation potential is at very low lung volume, so close to residual volume, when the dependent lung regions ventilate poorly owing to the weight of the lung, causing small airway closure, decreased ventilation which is relative to the non-dependent region, which will ventilate better. Once FRC is reestablished, the lung volume increases and airway closure is overcome, and the typical pattern of ventilation resumes. So from the earlier discussion of the determinants of ventilation perfusion, the effect of gravity and posture were discussed. This is a good graphical representation of the relationship between ventilation and perfusion as it relates to dependent and non-dependent lung regions. So gravity and posture are among the most important determinants of VQ matching. In adult ICU, prone positioning is a common strategy employed for patients with refractory hypoxemia and acute respiratory distress syndrome physiology. This was particularly helpful during the pandemic. For the reasons previously mentioned, lung compression is less, ventilation is better, matched to perfusion, and oxygenation is improved. And now the relative ease of proning of our NICU patients works to our advantage, although there may be some perceived barriers to this, including the desire to be able to evaluate work of breathing, protect umbilical lines, or for ease of serial examinations. But in fact, prone positioning would be preferred, the preferred position for optimal VQ matching, and the benefits far outweigh the barriers. So this is my last slide here. So in addition to positioning, the key management goals to keep in mind for optimizing VQ matching are to reduce dead space and decrease shunt fraction. Some of these points will help with both. So starting with ventilation, the goal would be to avoid hyperinflation or, if possible, any positive pressure ventilation, more so in the form of invasive ventilation. Next would be to reduce or avoid altogether as much as possible mechanical dead space. So deciding whether continuous and tidal CO2 monitoring is needed, or switching from a compliant to a more rigid circuit in order to reduce compressible volume. The next point can be technically challenging, but clinically very important, and that is to establish and maintain FRC and optimize lung recruitment and compliance. Attempting to oxygenate with the lowest effective mean airway pressure while avoiding atelectasis for the most part is the goal here. Next is to manage and correct hypotension. We know that it has a negative impact on pulmonary blood flow, and because alveolar pressure can more easily exceed arterial pressure, it limits blood flow to the areas of the lung, which increases dead space. And the last is right to left shunt, sometimes in the form of atrial septal defects or PDA. It can increase shunt fraction if the right-sided pressure exceeds systemic pressure. So when indicated, pulmonary vasodilator therapy may help to improve VQ mismatch. So I have a couple of summary slides, but in the interest of time, I will just wrap it up. Thanks.
Thank you, Michelle. Our next speaker is Dr. Audrey Hebert. Dr. Hebert is a clinical assistant professor of pediatrics in the Division of Neonatology at Laval University and staff neonatologist at CHU de Quebec. She is developing her research interest in the field of chronic pulmonary hypertension associated with bronchopulmonary dysplasia and training program development in TNE. Dr. Hebert's talk is titled Mechanism of Action for Common Inotropes and Vasopressors.
All right, thank you. I think everyone can see my slide, hear me fine. All right, thank you. So really happy to be here today and talk about mechanism of action for inotropes and vasopressor. So I have nothing to disclose. And then just to get started, I mean, inotropes and vasopressor can be kind of a scary sometimes medication to start in the NICU, but really there's not that many medications, and hopefully by the end of the talk, you'll get kind of sorted out with the the different inotropes and vasopressors we can use, there's a few things that we need to remind ourselves when deciding which inotropes and vasopressor to use. So really the treatment, like really anything in neonatology, should be tailored to what's going on with the patient. What's the physiopathology? What's the underlying disease? And why is the patient hypotensive, and why does he need medication? The other important thing is to kind of remind ourselves that neonatal cardiovascular physiology is actually quite complex. And sometimes we kind of aim to maintain a normal mean arterial pressure, but really that shouldn't be the end goal. It should be that the patient, not only blood pressure, but perfusion and clinical assessment is stable. And then we also need to remind ourselves that the science that we're using, especially for that medication, is usually coming from adult, pediatric, and animal studies. We don't have a lot of studies using those medication in neonates. We have a few using dopamine, sometimes dobutamine, but that's pretty much the end of it. We have some observational studies, but not a lot of good RCTs were made using those medication. And I kind of like to see the use of the medications in the unit, that we see dopamine being the one fairly the most common one, and some medication really not being used that much, but we'll talk about all of them today. Also, a few things about the newborn heart, because newborns are not small kids. We always remind ourselves of that in the NICU. There's some specificities about the newborn and especially the preterm heart that are important to know when choosing which medication to use. So the patients are, especially in preterm heart, the heart is actually less contractile and quite easily overwhelmed. That means that there's fewer and more disorganized contractile tissue. There's also a lot of immature myocytes, and the adrenergic system is quite immature. And that's really important, because what it does is that there's going to be more alpha-1 receptor than beta-1 receptors, and we'll be talking about those receptors, but the alpha-1 are really the one responsible for vasoconstriction. So really when you have more alpha-1 receptors and you're giving a drug that favors those two receptors, usually the preterm will have a higher response to peripheral vasoconstriction. So talking about adrenal receptors, I mean, we have not that many, but it's really the ones in the heart and then the peripheral vasculature. So in the heart, we have the alpha-1, beta-1 being responsible for contractile force and the heart rate. And then we have the alpha-1, beta-2 in the peripheral vasculature, which are responsible for the vasoconstriction, and beta-2 being responsible really for vasodilation. So this is the table that we often see, looking at all the receptors and kind of what they do. Do they do vasoconstriction? Do they do vasodilation? And honestly, I'm a very clinical person. When I'm at bedside, I don't really think that way. Do I want to play on the alpha, beta? Really, I kind of want to think about my patient. Do I want to raise systemic vascular resistance? Do I want to lower pulmonary vascular resistance? So, and that's really how I want to present it today. And because that's really how I think clinically it makes more sense. So talking about different agents, we will be talking about dobutamine. So dobutamine is a beta-1 and beta-2 adrenergic activity, and it has a little bit of alpha-1 also. What it does, dobutamine is really good at increasing cardiac output, especially in myocardial dysfunction. So you're going to have an increase in cardiac output and an increase in stroke volume. You may have a bit of side effect because it does have a chronotropic effect. So it might become, your patient might become a bit more tachycardic. And also it will reduces the smooth muscle contraction, which will lead to peripheral vasodilation. It is not as a potent peripheral vasodilator than milrinone, which we'll be talking about, but it might create some peripheral vasodilation. Good clinical indication, really, it's when your patient, you have a dysfunction, a heart dysfunction, and you want to improve myocardial performance, dobutamine will be a good choice. So if you have a patient with cold septic shock, cardiogenic shock, or even a large PDA that is causing some issues, then dobutamine might be a good drug. Moving on to milrinone. So milrinone is a selective phosphodiesterase 3 inhibitor. What it does is that it will increase the cyclic AMP, which causes vasodilation, especially in the pulmonary and systemic vasculature. So milrinone will lower your pulmonary vascular resistance, and it will also lower your afterload. Milrinone is also present, the phosphodiesterase is also present in the myocardium. So milrinone will act as a positive inotrope, leading to a better contraction. And it's also an agent that is a lusitrope, which means that it creates cardiac relaxation, and that will improve filling of the heart. So milrinone might be a good agent to use when you want to improve myocardial performance, if you have heart dysfunction, and if you want to lower your pulmonary vascular resistance and your systemic vascular resistance. So great agent if you have a patient with pulmonary hypertension. Good agent also if you have a post-PDA ligation syndrome. It's also being more and more studied in congenital diaphragmatic hernia. So milrinone can be a great agent especially if you have pulmonary hypertension. However, milrinone, a bit of cautious use, especially if you have systemic hypotension, because if you remember, it will create systemic vasodilation, which will most likely lower especially your diastolic pressure. So if your patient is hypotensive, milrinone might be a drug to avoid. Another issue with milrinone is that it's mainly is created by the kidneys. So if you have a patient who has kidney issues, especially in therapeutic hypothermia and asphyxiated patients, milrinone may be kind of not excreted, and milrinone has a long half-life, and then you might have issues with your blood pressure, which was actually shown by Agent Bishop and her group in Toronto and Iowa, in patients with cooling. They saw that the patient that received milrinone had much lower systolic and diastolic blood pressure. So a bit of caution when using milrinone, especially if your patient is hypotensive. I tend to actually avoid using milrinone in those cases. The common vasopressor agents. So we have dopamine, norepinephrine, and vasopressin. So dopamine is obviously a big one in the NICU. It's by far the most commonly used and studied agent. Why? Well, it will increase the blood pressure. So, I mean, if you have a patient who's hypotensive, you start dopamine, probably you're going to have a good response on blood pressure. It's also an agent that people are familiar with. It's commonly used, as I said, so people tend to kind of go towards something that they're familiar with. So dopamine, what it does pretty much everything. It's an alpha, beta, and dopaminergic receptor. So it will increase your systemic vascular resistance because it really does peripheral vasoconstriction. It will also increase your pulmonary vascular resistance. It will increase your heart rate, and it will increase your myocardial contractility. However, dopamine is highly variable, especially in preterm infants. And if you remember at the start of the presentation, I did say that the preterm heart had a lot more affinity for alpha-1 receptors. So usually dopamine in preterm infant might actually create even more vasoconstriction than kind of the other effects. Dopamine is also dose dependent. There's a bit of it's not very much of a controversy anymore. We don't really believe that dopamine at a lower dose will have any renal effect, especially in newborns and infants. And at higher dose, dopamine actually will create even more peripheral vasoconstriction and decrease cardiac output. So dopamine, I mean, you need to kind of be also cautious when using dopamine, especially when you have a patient with refractory hypoxic respiratory failure. I mean, this is an experiment that was done in 2001, and it's an animal study. But what they show is that when using dopamine, the systemic resistance did increase. So your blood pressure did increase. However, it also increased your pulmonary pressure and 2 times more than your systemic pressure. So if you have a patient who has pulmonary hypertension, which obviously it's often the case in the NICU, right? We have patients that are usually transitioning, very at risk of pulmonary hypertension, and you're using dopamine. Well, dopamine can actually might increase even more your pulmonary pressure, and that might be an issue. And this was actually illustrated in a recent paper by Dr. McNamara, and this is a beautiful image from that paper. But what does dopamine it does is that it increases pulmonary resistance, favor vasoconstriction, and then it increases RV afterload, and then you actually end up increasing your oxygen demand through the heart, and really creating more hypoxemia. So really, when you have a patient with acute pulmonary hypertension, dopamine should actually be avoided. Moving on from dopamine, norepinephrine is I think we're seeing it more and more in the NICU. Not a lot of studies on norepinephrine, mainly an agonist of alpha and beta 1 receptor. Really what it does, peripheral vasoconstriction. So it will increase your systemic vascular resistance. There's not that much effect on cardiac output. One of the side effects being tachycardia. It's a great agent to use when you have a patient with warm septic shock. So if you have that patient who's kind of red, vasodilated, flash refill, bounding pulse, norepinephrine will do kind of peripheral vasoconstriction. So that might really be a good indication for norepi. And we have some studies coming up. So hopefully we'll have more data on norepi in the future for our patients in the NICU. Vasopressin is also kind of a newer agent being used in the NICU. Not a lot of studies, mostly a case series and observational studies. Its main effect, it's an interesting, I think, agent, especially when you want to kind of create the pulmonary vasodilation, so just lower your pulmonary vascular resistance and increase your peripheral systemic vascular resistance. So if you kind of not going to have that much effect on your blood pressure, but it might increase a little bit your blood pressure by creating peripheral vasoconstriction. And if you have pulmonary hypertension, it might be a good agent to use also for the pulmonary vasodilation effect. Again, vasopressin, a bit of caution when using it, especially personally, I always start vasopressin after having an echo, just because if you have a left ventricular dysfunction, dopamine does not have any really good inotropy, meaning that it's not going to support the heart function. So if you start vasopressin, and it's going to increase your systemic vascular resistance, which will increase your afterload, and you don't have an agent that is there to support your heart function, then vasopressin might actually not be a good fit, just because there's no support for that heart function, and it will increase your afterload. So a bit of cautious when you have LV dysfunction with vasopressin, and vasopressin having an effect actually on ADH. It will actually cause hyponatremia. We see it clinically when we use it. So I mean, it's something that can be corrected with different fluids, but it's a side effect that we see, and we should be following sodium levels. And then we have two more, epinephrine and corticosteroids. So epinephrine is really kind of an agent that does a lot, actually. It's alpha, beta 1, beta 2 receptor. So it will increase your stroke volume, your cardiac output, it will increase your systemic vascular resistance, and it will increase your pulmonary vascular resistance. Very much dose dependent. So the higher you go, the more you're going to be stimulating that alpha 1 receptor. So that means that it's going to be really increasing your systemic vascular resistance. So usually we try not to go too high on the dose, just because we don't want to create too much vasoconstriction. So epinephrine really is a good agent if you have a patient with cold septic shock, if you have a patient in cardiogenic shock. Even in pulmonary hypertension, it does increase pulmonary vascular resistance, but as opposed to dopamine, which was increasing 2 to 1, it will usually increase 1 to 1. So epinephrine can be, a good agent for really many many etiologies in the NICU for hypotension. Again, a bit of caution when using epinephrine, especially at higher dose or longer exposure. You might have, it's been described to have some myocardial injury and ischemia. And another issue with epinephrine is the side effects. So it might increase your plasma lactate and your serum glucose. What the issue is that when you have a patient who's hypertensive, not doing well, needing pressors, and then you start epi, and then the lactate goes up, is it because your patient is clinically deteriorating and not doing well, and then the lactate is going up, or is it because your epi is a side effect of the epi? So it's something to know. It can be hard sometimes to see at the bedside, is it really the patient or is it the side effect of the drug? But it can be the FP that brings the lactate up. And then corticosteroids, even though it's not really an agent, it's not a vasopressor per se, can really be used, especially in refractory shock. So when you have a patient that is hypotensive, not responding to your agent, then corticosteroids might be a good, it might be actually a good addition. It will have an effect on actually increasing your adrenergic receptors, and it lowering your capillary leak. So corticosteroids, I think, is a good agent to have in mind, especially when you have a patient who's not improving and you need to add other agents. So this is a table that I really enjoy, and comparing to the first table that I show you with all those receptors and are we creating vasoconstriction, vasodilation, this is from Dr. Giesinger paper. And I think this is how I think when I'm at bedside. What is it that I want to achieve with that patient? What is going on with the patient? Why is the patient hypotensive? And what's my goal? Do I want to increase stroke volume? Do I want to increase systemic vascular resistance? Or do I want to lower pulmonary vascular resistance? So depending on what my goal is, well, that's really how I choose the agent that I'm going to be using. So nice summary, but this is really what I went through today. And this is really how personally I think about agents when I'm at bedside, and what's the aim, what's my end goal with using the agent. And then really that's, there's going to be a presentation later on this week about really using agents and more kind of the clinical side. But this is really just a summary of what I said today of, thinking about kind of the physiopathology of the disease, and which cardiovascular therapy should I be using depending on what is going on with my patient. So really treatment should be tailored to the physiopathology of the disease. And I think one thing is to remember is, like anything really, not only with cardiovascular agent, but if your patient is not improving or is deteriorating, well, maybe the choice of inotropic vasopressor is the problem. And, you need to reevaluate and think about what is the underlying physiology and what is going on, and should I be using a different or adding another agent. And obviously careful monitoring of the patient beyond blood pressure and beyond the mean blood pressure is really needed when we're using those agents. So thank you, and I'll be happy to answer any of your questions.
Thank you, Dr. Hebert.